Thanks to Ian for his very kind invitation. 12 years after I left Royal London to take a job at the UCH, and it's pretty obvious why I was the consultant here and the senior registrar. He's so young, even after all this time. But today, indeed, I want to talk about something which 12 years ago was not part of the cards when I started, but gradually is moving to be my professional lifeline and the topic that really lies in the depth of my heart. And this is sarcomas, which, as you know, is obviously cancers of the body, starting from mesenchymal cells, and with regard to the head and neck, pose a substantial difference to what we have the most common and conventional mouth cancers, because mouth cancers, which are 90% are squamous cell carcinomas, and epithelial cancers, are soft tissue diseases which expand into the hard tissue. Sarcomas in the craniofacial region, in the head and neck, are mainly bone diseases or diseases starting from the bone and expand the soft tissue. So it's actually the opposite model. And this has implications in the type of treatment. This has implications in the outcomes. There is also another difference. There's another difference between head and neck sarcomas and typical mouth cancers. And please excuse my political incorrectness to this, but head and neck sarcomas involve, in general, in average, a younger group of population, people with lots of things to do in their life. Everybody has lots of things in his life, even to the very last day. However, involves a group of people with no environmental issues related to the disease. Non-smoker, non-alcohol abusers, and people who, from one day to the other, their whole life turns around and has a huge emotional impact and influence on that as well. So, just to give you a feedback on that talk, I will talk about a period of 1997 to 2010. At 1997, I was not at the UCH. I was starting as a registrar of the high school, so there was a colleague of mine there who started this. There are two people, Jeremy Whelan, because nothing medicine is just one person's job, is a combination, is a teamwork. So Jeremy Whelan that time, Dr. Whelan, nowadays Professor Whelan, is the guy behind the chemotherapy suite, behind the oncology part of sarcomas, and sarcomas are very well tied up with chemotherapy, and I will explain to this. Not as much with radiotherapy. So this review from 1997 to 2010 is an audit of 107 cases. It's a very, very large audit. The published series of sarcomas are not more than 40, 50. Here in the UK, we have benefit that, for reasons which I'm not aware of, we decided to have sarcoma centers. Uniquely on what happens all over the world is not only cancer centers, but sarcoma centers. And I benefit from the mere fact that UCH is one of the 5 centers in the whole country treating essentially almost 10% or 50% of all head and neck sarcomas of the country. So these are data from that period of time. This is roughly a breakdown on males and females. If you see the breakdown on hard and soft tissue is almost identical, 54, 53. Similar number of distribution on gender. So gender is not 1 to 3 as it used to happen on female-male ratio for typical squamous cell carcinomas. And obviously the age group has the rather bimodal, sorry, apologies, let me see if I can use this one, has the bimodal distribution, which we know for the typical sarcomas, mainly of the trunk and the limbs, mainly of the bone sarcomas. So again, most common bone sarcomas in the head and neck are in the mandible, 1/3 of them in the maxilla, and the rest we call it extragnathic, cheekbones, even hyoid bone, cricoid, everything else, but only 1 in 10. The soft tissue sarcoma distribution is exactly the opposite, as you would expect. I will not bother you a lot with the histopathological classification of sarcomas for lots of reasons. The main one is sarcomas are very richly distributed in several types of histological, histological classifications. Usually we just name it as low grade, high grade. I will come back on histology by showing you, for example, the histopathological classification of soft tissue sarcomas. And if you see here, everything is distributed in very, very small slices. Nothing, there is no overwhelming majority with regard to the soft tissue sarcomas. But let me go back on the bone sarcomas. So that's the annual incidence, 8 in 1,000, in a million. Bimodal age and gender distribution. Mandibular sarcoma, as we said, is the most frequent bone cancer of the head and neck, and histologically is osteoblastic, chondroblastic, or fibroblastic. The other 2 parts are the Ewing's and the chondrosarcomas. I'll be very simplistic. Well, chondrosarcomas are called so because of the production of chemocartilage, and whereas Ewing's sarcoma is the most common sarcoma in adolescents, and the second most common primary malignant bone cancer. I'll come to the treatment in a minute, but even by seeing this slide, I can tell you the 2 top ones, the osteosarcomas and the Ewing's, they need a combination of chemotherapy and surgery. You can't avoid this combination. The chondrosarcomas, they have only one modality of treatment, which is surgical excision. There is no role for chemotherapy or radiotherapy. A pie with the distribution, the histopathological distribution, and we discussed already about the soft tissue sarcomas. I'm moving quickly on the treatment strategy for sarcomas, for the bone sarcomas. And I will tell you straight away, these are not validated data. These are more data of experience, so empirical ones, but they're data that somehow contradict the typical ways of treating, let's say, mouth cancer. I'll become specific. So, in accordance to what we do for trunk and limb sarcomas, which are the most common of all patients are submitted to neoadjuvant systemic combination chemotherapy. Why we do so? Because what is expected, and this is an extrapolation of the treatment happening in the limbs. In the limbs, you do so, you expect you can spare some amputations, you can do tendinectomies, you can remove part of the limb without need to amputate it. We can't say the same for the craniofacial, for the head and neck region. However, what we can say that the neoadjuvant chemotherapy is used, 1, to make sure we reduce the risk of distant metastases, lung mets, which are not uncommon in sarcomas, certainly much more common than epithelial tumors. And number 2 is an indicator of the biological response. Disease which responds quite well in neoadjuvant chemotherapy, most probably it will have a favorable outcome. Not all the time, but it will respond well on surgery as well. Disease not responding at all in any sort of chemo may not work out that well. So, how we measure response on chemotherapy is a histopathological measurement, and basically you have to have more than 90% tumor necrosis. So the outcome of chemotherapy is depending on the surgery, because you need to remove the specimen, the diseased part, examine under the microscope, and only then you can identify necrosis rate. We use as interim measures the PET-CT, but the problem with PET-CT, post-emission tomography, post-emission tomography in combination with computed tomography, the problem with that is we cannot differentiate very well between true active malignancy and inflammatory response on the drugs. Therefore, the response to PET-CT is mired with relatively quite false positive rate. Still, we see quite substantial false positive PET-CT results, not necessarily representing the tumor necrosis rate that we may see in the specimen. However, is the best instrument, the best weapon that we have in our possession at this very moment to assess interim response. Why I made all this huge introduction? Because we give 6 cycles of chemo, the oncologist gives 6 cycles of chemo, neoadjuvant chemo to start with interim radiological assessment, every 2 or 3 cycles, a PET-CT, in combination, obviously, with the clinical progression or not. Radiotherapy, I said right from the outset, has a very little role in sarcoma treatment. Why is that? Because sarcomas are considered radio-resistant, and therefore we use radiotherapy as palliative or positive surgical margins. I wrote this here, and I regret I have not seen a single case with positive bone margins, and I'm talking for bone sarcomas now, which has been salvaged with radiotherapy. This may apply to soft tissue margins, but if there are positive bone margins, then the only treatment is metastasectomy, removal, further excision of the tumor. I will come to the point in a minute. So that's roughly the treatment strategies that we use for osteosarcomas. Please feel free to stop me any minute if you think that you should ask something. The same for you. So again, these are the surgical principles that we implement, that we try to conceptualize and apply in the London Sarcoma Service. There is some differences on what we do with regard to epithelial tumors. Hence, I say clearly, you may be an excellent surgeon for mouth cancer, but sarcoma treatment is different. You need to think the opposite model. You need to think from inside out. You don't have a tumor going from the soft tissue to the bone by default or by proximity or by vicinity. You have a bone tumor which you cannot assess. It knows no anatomical barriers, because once something's in the bone, it doesn't stop. There is nothing to stop it, which by default may expand to the soft tissue. So bone tissue matters a lot in treatment of osteosarcomas. So the first line is pretty basic in every part of surgery. As Jan will tell you, there is no way that you can do cancer surgery without having in mind that you ought to remove and block a wide resection of the tumor with sufficient soft and hard tissue margin. So let me show you this patient a few years back. This is, believe it or not, post-chemo. And it's important to say, because you can see here the multifocal lacunes, like big cysts that exist there. And indeed, once you have something like this, the radiologist explained it and said most probably these lacunes represent tumor necrosis, which may well have been, but I'll show you in a minute. From a surgical point of view, unfortunately, is not as helpful as I would like to be, for the very simple reason I do not know which are the anatomical barriers between the advancing tumor front and the normal tissue. And unfortunately, cancer is not like a balloon which is inflated and you give something and concentrically shrinks down, gets deflated. Unfortunately not. You may have tumor necrosis here on the periphery, but you may have active disease in the middle. And you know this only when you remove the whole area. Of interest, please assess how little you can see on the normal regular X-rays. So this is how it looks like pathologically when it's removed. So you can see a blood-filled network of spaces and blood-filled cystic spaces with tumor necrosis. However, histologically again, I'm told that these are tumor cells, so I don't pretend I'm a pathologist. But you can see tumor cells lining onto the cystic space. This is the importance, yes, this is the importance of wide surgical excision. Yes, indeed, the tumor necrosis, as I said before, may be a good biological indicator of tumor response to treatment. Unfortunately, cancer is not a balloon, even a sarcoma, you can deflate it and the whole thing will shrink down. So, if we don't remove all these lacunae that we saw before, these tumor cells will be left behind with unfavorable outcome at the end. And some more data here, and this is the outcome after surgery. So I used 3 flaps. Actually, I could do with 2. I used the 3rd one because I took the measurements wrong. I have to say, sorry, but this happens from time to time. Is a huge defect to identify what is the external skin requirements. It was more than I expected. So anyway, as everything, and I'm not going to give a lecture about reconstruction now, but things are pretty basic. You need a cover for the outer skin, a cover for the inner lining of the oral cavity or the windpipe or the foot pipe, and obviously the sandwich in between, which is the bone. We need to isolate the oral cavity from the rest of the world, because oral cavity means saliva, means open, full of bacteria area, and if this communicates with anything else, it will cause a huge communication with the corrosion of saliva and all the bacteria. So the basic principles are restoration of an intact oral cavity, provide intact inner lining, provide intact outer lining. Try to put a bit of bone in the middle. So this is how Marlena looks now, after a month ago. Still lots of work to do, and I'll come to this, and you can see some implants at the end and teeth as well. Something else which I think is pretty important. Chemotherapy, said for the 3rd time, may be seen as a biological indicator of tumor response. However, and that means that at least the soft tissue component of the disease may shrink considerably. For the reasons which I mentioned before, namely the non-concentrical shrinkage of the tumor, the resection has to be based on the pre-treatment soft tissue assessment. It can't be based on what we see. Trust me, this is through hard experience. It is tempting to say, no, we have tumor there, radiologically we cannot see anything spreading elsewhere. The resection has to be based on what you saw before, not what you anticipate is radiologically evident after completion of treatment. In sarcomas equal to epithelial tumors, you can see an initial response to chemotherapy with shrinkage of the disease. With not radiologically evident disease, 3 or 4 months later, if there's no further treatment, the disease will come back with a vengeance. So, indeed, this is on the pre-chemo assessment. This is how the patient starts. This is the 6 cycles after chemo, substantial shrinkage, and this is how edges look after the operation, immediately after. So loss of hair due to chemo. I usually use a lateral axis. I'm not going to bother you that much with surgical details, but I avoid surgery for head and neck is not Zorro type. I hate skin cuts in the middle of the face. We have to take in consideration aesthetics. If you ask me what has changed the last 10 years in cancer surgery, I will tell you that personally, I feel when I was Ian's registrar, every patient we were treating, and we treated lots of them successfully, had one big operation because of lots of other things. However, there was not enough tweaking, there was not enough improvement on the aesthetic considerations. Not for any other reason, but this is also how the whole thing are evolving, including the patient's perception. And through saving faces, through changing faces, through public awareness, people like edgers, people like my friend Judy, they are not happy, that's rightly so, to be only healthy, but really they want to be back as they used to be. So it's important for this, it's important for a surgeon to take things into account even before start surgery. You can't undo a bad surgical beginning. I think this is, the next point is the most interesting point from my point of view, from surgical point of view. Sorry, just only for people who have some surgical experience. In the head and neck, there is, amongst maxillofacial surgeons, there is an endless discussion about the importance of saving a piece of bone, a piece of this, that, the other. Personally, and I mentioned before, sarcomas, bone sarcomas, are the opposite model of an epithelial tumor. 1. 2. You cannot salvage bone positive margins. Therefore, do not think twice. If disease goes onto the rames, on the ascending rames of the mandible, please proceed to disarticulation. Just remove the whole lot. Next, we are going to hear about TMJ replacements. I can tell you, and we're going to publish this data pretty soon, after 25 people with resected condyle, the mouth opening, which to me is one of the most important parameters of assessment, is practically back to normal, about 3 centimeters. The deviation of the jaw is less than that to be considered, not negligible, but not particularly worrisome. So, after that introduction, and I'll explain why I'm saying this, you can see the ramal involvement here. You can see, by the way, nothing on the OPG. And please look how the tumor looks like here. That's the bone, that's the soft tissue, medial pterygoid, and the buccal space with the masseter, and the bone goes all the way up the bone. That's the bone here. That's a beautiful macroscopic picture from one who was trained also here, Whitechapel, from Dr. J. And I find this far more interesting because you can see the tumor. That's the bone of the mandible. And this is how the tumor is creeping along the mandible with osteoid component and chondroplastic component. And it's creeping along the mandible. Normal muscle here, and the tumor goes up like this. And even more, what I mentioned before about the tumor necrosis rate, necrotic and viable tissues mixed together after chemotherapy. And the pictures that you saw before, the x-rays that you showed before, the condyle radiologically was absolutely intact, and very interesting enough, you can see the head of the condyle, that's it here, with infiltrated marrow spaces which reach in the subarticular bone end plane. So there's no way that you can, in very plain words, there's no way you can remove all this and without leaving tumor behind, unless you resect the condyle itself. Consideration of spread to infratemporal fossa and base of skull, very important because this is the area, some of the areas that we fail. I'm not going to bother you a lot. I will show you this is the facial nerve which has been dissected, and again some of the excisions, but clearance of the infratemporal fossa is of paramount importance. Last but not least is what I preach all this time is the potential bone marrow involvement beyond the pre-surgical radiological findings. MR is an excellent tool to assess soft tissue involvement. It's an excellent tool to assess through the negative image potential periosteal involvement, i.e. potential cortical bone involvement, and that's what it is. It's very difficult to assess bone marrow involvement. There is no anatomical barriers to contrast with, neither on the CT. So, very small lesion here. This is how much was assessed. Massive resection here. I was criticized about this. This is how it looked on the occlusal view. And the sagittal sections showed, again, disease much more widespread on the labial, on the lingual. It looks how the disease is creeping along the bone here. And some more histological data showing histological patterns of disease spread which are not possible to be diagnosed on the pre-surgical imaging. Ways of reconstruction, I will not bother you with that. I think I'll need to say a few things about this because to me is one of the points of interest. I think if you contrast this lady from that picture with this one, it says a lot. Is after a jaw resection, still unhappy that years and years after the operation it didn't look symmetric. I don't say it's perfect, but following fat transfer, Coleman fat graft injection, some sort of suspension and plication of the mental muscle, symmetry improves, looks better, feels happier, and that's really much, much more important than anything else, I think. So, few things about the survival. That's the figures that we had out of 104 patients, which is one of the biggest series that have been published. So 79% at 2 years, 64% at 5, and that's for all sarcomas. If we break it down to bone, the overall survival and the event-free survival, and if we break down to the bone and the soft tissue sarcomas, you can see the differences. So the bone sarcomas have better survival in 2 years, 91%, 67% of the soft tissue, 73 and 56. That's the survival probability according to the site. So bone extragnathic bone sarcomas have the worst outcome. That's quite logical. It's relatively more difficult to get appropriate margin when you have disease on the ethmoids or the lacrimal bone, much more difficult compared to the maxillary mandible. While if we want to see the survival probability according to surgical clearance, again, we see the importance of margins, especially on the soft tissue sarcomas. So I won't bother with that much more. I will just put these as with the published figures in the literature. 79% altogether, UCLH data, 64% at 5 years. That's the data from MD Anderson. This is data from Dörzak, and on the soft tissue sarcomas, pretty similar, if not slightly better data than Van Dam in Amsterdam, but actually no statistical differences. Few things they need to take into account. The heterogeneity of sarcomas, as I said, the histopathology of sarcomas is almost every second case has just a description of a spindle cell tumor, which is just a topographic description of cells, but not saying anything more. Variations of study population, what has been studied, and obviously the diversity in the follow-ups that have been reported. Many thanks.
Right, so I was diagnosed in October 2009, and I'll show you a picture of how I looked. Is it that way? Yeah. Now, I was diagnosed with spindle cell sarcoma, and I was diagnosed at Northwood Park. and I was very quickly shuffled off to UCH because it being the Sarcomas Centre in the southeast. And I think there was 1 month from diagnosis to beginning of my chemo. And within that month, I also did a round of IVF as well. I mean, there was so much was crammed in, my feet didn't touch the ground. And then Professor Whelan was my consultant and still is, and I embarked on a very aggressive chemo regime. So this is in the way, isn't it? I would spend 1 week in every 3 in the hospital, and it was full on. It was full on. The experience as a whole, I mean, I was treated with kid gloves, and I really don't have anything bad to say about, the oncology side of things was amazing. And the communication between when I started sort of being introduced to Nick's department in the head and neck, it was seamless. And I guess we kind of met up. So I started chemo in November. I kind of started talking to Nick in February, and that was when we started talking about what would happen, what Nick would do. And this, yeah, sure. It might come across a bit dark. So I lost all my hair. That was probably a couple of weeks before the surgery, actually. And my pictures are a bit different from a lot of the ones that you showed, because I didn't have an obvious lump. Mine was just destroying the bone from within. And it was the strangest thing, because I was kind of sort of shifting back a bit. I was shuffled between my dentist and my doctor because they couldn't work out what it was, and trigeminal neuralgia was mentioned. Previous, like there was possible injury where I might have hurt myself. It was really quite rubbish. And I stopped sleeping, and I started getting all kinds of viral infections, and it was just awful. So actually, when I got the diagnosis, it actually, yes, it was absolutely devastating, but it was brilliant, because it meant that this madness that I thought, what is going on, could actually be dealt with. So when we embarked on getting into the nitty-gritty of the surgery, I would say, hand on heart, I cared more about what I was going to look like than I did about what Nick was going to do with the cancer, with getting rid of it. We were talking about this earlier. As a patient, cancer is a really abstract phenomenon. I don't know what it looks like, you guys do, but I couldn't kind of, there was no point in kind of becoming all maudlin about it. I just needed to concentrate on what the surgery involved. So the chemo was probably about 5% of the aggravation. The surgery was about 95% of it. The surgery is enormous, absolutely mammoth. I can show you a picture how I looked with the intensive care. So I had a mandibulectomy done twice. And the first one was done, it was the end of April 2010, and I think the operation was about a 12-hour op or something outrageous. And what Nick did was, I'm just going to step here because then you can see, he took my fibula bone and used that bone with all the soft tissue to reconstruct my lower jaw. With a titanium strap. And a couple of days after the first major op, I had to go back into theatre because Nick wasn't happy with the way that the blood vessels, I think there was something to do with blood flow, or there was something, anyway, I went back in. And I do vaguely remember being brought back round, because afterwards I remember having a row with my husband about it, because he said, "You've had 2 operations." I was like, "No, I haven't, I've had 1, you know." And it was quite a bizarre experience, actually. And unfortunately, I suffered really badly with hallucinations in intensive care. And when I came round, I had this really odd sensation in my foot, where if something was like, say, that far away, I could kind of feel it without it touching me. And it transpired later on that I'd actually got something called chronic regional pain syndrome, which happens. That kind of surgery, it happened. But we didn't know that then. It kind of came out later when I had my second lot. So I couldn't walk, I couldn't talk, I was hallucinating like a maniac, I was in a lot of pain, and it was a really scary place to be, actually. The first 2 or 3 days up on ward was like, probably like being in a horror film. You know, I kind of scared myself. All of the secretions and the gory bits and the bits that the nurses were kind of cleaning up, and it was, nothing could have prepared me for it, nothing. And it was a very alien experience. And then with the very sort of kind and loving care from the team, that first sort of 3 days, thankfully, it's you know, it's great. From that point, you know, when you start actually getting out of bed when you're up on the ward and starting to learn to walk, and you're getting the secretions going, and you know, the trachea, and it's all about getting the trachea out. And it was long, it was hard, it was dirty, mucky, absolutely no dignity in cancer whatsoever. You know, it's talk about childbirth, but honestly, that is something else. Then I guess I was discharged after about 2.5 weeks. Now, bearing in mind, I was only 5 weeks, so when I'd had that op, I was 5 weeks from having stopped chemo. So I was still quite weak, and my body was trying really hard to kind of keep up with the flow, I suppose. And then went home, you know, I was concentrating on learning to walk on both feet again, even though I was in immense pain from this chronic regional pain syndrome. And then we got to the point where we were talking about pathology results. And I was so naive, because I just figured, I didn't think that I'd be there again. I just figured I've done everything I've asked. You know, I've run this marathon with the chemo, I've done it again with the operation. And then Nick gave me the news that the sarcoma, there were cells that were found on the margin. And you gave me quite a big margin, I think, as well, because originally it was from here to here, wasn't it?
Do you mind if I show some?
No, go for it.
So this is the X-ray, so it was like this. And I think this very recently, and many thanks that you brought this.
That was
I know. So you can't see anything here, and neither I, Judy May can, but certainly I can't. The problem is that the radiologist couldn't see much either. He couldn't see on the CT scans. So after preaching all this about massive resection sarcomas, because it's the opposite of an epithelial tumor, I did proceed it, and always there is, I think when we do this type of operations, do not overdo. And I did it, and there's not more devastating news than to have a pathology which is positive. This was duly 2 years ago, almost to the day. Now there are no blades anymore. So when I was told that the pathology, Judy's pathology was positive, the simplest thing is just undo the whole lot, and this is against human nature and against human thoughts. undo the whole lot, throw everything in the bin, and redo the whole thing. And I said to Julie, both of us need to find the strength to realize that what has happened, and I will go wild with the section that I was told is 2 centimeters or 3 centimeters or whatever. Throw everything in the bin, we'll use as much bond as we can have. The whole reconstruction, that's what I mean, the whole reconstruction that Julie had in the first go, thrown away.
Because it was compromised by what was still there.
Because possibly was compromised, was seeded with
Yeah.
cancer cells. It's very difficult to differentiate where's the tumor from and the non-tumor from. And Julie was kind enough with me to allow me to tackle the other side of the leg. She didn't enjoy only that much the first one, she had the second leg as well.
But Nick did it slightly differently this time. Instead of, because the first procedure, have you got that photo there? That they can
The
see?
leg.
Yeah, that's, so this one that you can see here was this first side. And if any of you want to come down and have a closer look, do. I'm rather proud of it. It's, yes. So that is how that looked. That was probably the first picture, so that was when the dressing came off while I was in hospital still. And I'd say that it took probably about 6-8 months to kind of look like this. And I had a skin graft taken from up here, which was put down on this area. And I've got to add this because Colin Lou said to me that he thinks it's one of the best skin grafts that he's ever seen. So that's Stefano that did that. Because it's just, you can't see it. The skin graft is amazing.
So this picture is of someone else.
That was how it looked originally, but now you cannot see it. Only if I have a bath. Right. Anyway.
But they can come and have a look and touch if they want.
They can. I'll drop my trousers if you want. So the day that Nick told me that I had to have this done again, and it was. I kind of every now and again I kind of replay this over in my head because it was such a. I mean, for me, obviously, it was a very profound moment, and in terms of life-changing events, I remember going into this room with Nick and my husband, and my mum and dad were there as well. And then Nick and I, he said to me, you know, this is not straightforward, and I think that, you know, we need to do this again, but. And then I was aware of another person that was in the room, the radiotherapist. I don't know her name, the lady with the long hair. She suddenly appeared and she was there, and I remember thinking, what are you doing here? And Nick was offering me, I think, like a temporary get-out, because I think it was always going to end up with surgery, even if I had done radiotherapy. And I remember we had this very brief, and I said, well, what's the point? We need to do this surgery, just get it out. I just want it gone. And I don't, because of the way Nick described it to me at the time, saying, yeah, it's compromised, we're going to have to do it again. We're going to have to get rid of all of it and start again. And it made complete and utter sense to me. There was no, oh my God, but can't we save anything? You know, it was just get this out of me, you know, we've got to do it. And I remember saying to him, because I really struggled with my right leg, learning to walk again on that, because it was so painful. And I remember saying to him, so when are you going to do it? And he said, Monday. And this was Tuesday. And I can remember thinking, what? I'm not walking properly yet, are you crazy? And he's like, no, we're doing it on Monday. So that was that. We went for the second one, and actually, doing it a second time, even though it would have been great not to, I think doing it a second time, I was a lot stronger because I was a lot further on from chemo, and my recovery was so fast, and I was looking after myself in hospital really, you know, my left leg was perfect, it was absolutely fine, you know, it couldn't have been better. I didn't have hallucinations, and it actually kind of, I think it probably helped with the trauma of the first operation, if that kind of is a bit perverse. It was. And then we got the final set of pathology results, And it was good news. And I remember you saying that, you know, I mean, Nick was just over the moon and said, you know, it bounced around the world, that other people had kind of, they'd been looking at the results as well. I remember you saying something about that, and it was just bloody fantastic. And then after that, it didn't stop there, you know. I mean, I've had lots of reconstruction since then, lots of procedures. At Christmas I had my teeth fitted down below, which has changed things again. You know, it's just constant change, and you're, as the patient, you're constantly sort of getting used to another set of sensations or feelings, and the relationship we've got is fantastic. I mean, it's pretty special. And with the rest of the team, the same, you know, the oncology team, you know, I really haven't, I don't feel hard done by. I don't feel like, you know, I don't think it could have gone any better, really. And Nick still to do all the cosmetic work, to do the fat injections and make me look like Danny Minogue if I want to. But we're kind of taking a bit of a back seat in that because I'm going to go through IVF. So I'm 3 years down the line pretty much. It's 3 years ago since you did the first op. And I got the all clear in August of that year, 2010. You know, there was no mucking about, there was no chemo, there was no radio after the surgery. It was a done deal. And you did an awesome job. Is there any questions? Because there's anything anybody would like to ask me about any of that?
I'm sure lots of people want to ask questions. It's a great story, a very challenging story. I've got a few questions to ask, but I won't ask them just yet. I'll let other people have a go first. So, you've heard about the general treatment of sarcoma. Why don't you two sit down? You've done your duty now, you've stood up, so sit down. And if you want to ask questions of Julie, Nick, or if Julie wants to ask questions of Nick, you can do that as well. So, you've heard about the general management of sarcomas of the head and neck, and also you've seen an example of somebody who's had treatment. And as you saw in the formal lecture from Nick, you saw that when patients don't have clear margins, they're not cured by radiotherapy, so they're faced with this dilemma, and you can see the result of that dilemma. So, fire away. Who wants to ask the question? The first question. Yep.
It sounds like it was quite hard to reach a diagnosis back at the very beginning. Like,
Yeah,
you said it's going between the GP and a dentist. And what symptoms were you getting at?
Well, I guess it kicked off about the year before I was diagnosed, so autumn 2008, and I got shingles, and then got rid of that, and then a month later I had a viral infection, like a strep C throat, and then I got another viral infection, and then I never, because I was in Centre Parks, and suddenly I got this toothache from out of nowhere. And I've had root canal before, I know what that is. And this was something else. It started up here and it travelled all the way down here, and it was worse at night. And I can honestly say it just came out of the blue, and I thought I was going to pass out. I genuinely thought, this is, you know, what's going on? And then I stopped sleeping. And my son was about a year and a half when this started. And so I had lots of visits to the dentist where I had root canals revisited and redone. I had a tooth out, and I remember that the root canal specialist that I saw, he took an x-ray and he said, oh, I don't like the look of that, that looks a bit dodgy. And I mentioned it to my usual dentist, and oh no, that's all right, that's all right. I changed dentists at that point, and then went and saw my old family dentist, and she sent me to a maxillary facial department at Norfolk Park. She referred me because she felt I needed an APG. Because what I had was this sort of, because there was so much else going on in my jaw and up here, and any kind of pain, tooth pain, it's very difficult to actually locate where it really is. Sometimes it can kind of, I don't know why that happens, you lot can probably tell me that, but it's very difficult to pinpoint it, and I had this semi-numb feeling here, and it just didn't go away. And when I had the first biopsy done at Norfolk Park, it was like having electric shocks. And in fact, the two people that were doing the biopsy, I was pulling on them saying, give me another shot because I can feel this. And I could feel every time they touched. So they were obviously going into the tumour, and it was like an electric shock. And thankfully, it took probably about 2 months to kind of go from that to the proper diagnosis. And actually, I must say that when they were looking at the results first time, they ballsed it up a bit because the people that were looking at it didn't know what they were looking at. They knew it was bad, but they just didn't know. And it was actually my consultant that he looked at it, looked at the results, and he'd seen it before once in his career, because it's pretty rare in the jaw. It's usually a long bone cancer, isn't it? So I was lucky. I think it was more than I was really lucky.
Can I just make a couple of comments there about what you said, Julie? The first thing is that we're all programmed. We function like computers when we're doing diagnosis. So what happens is that we are given a set of symptoms that we expect in a history and a set of signs that we expect to see, and that leads us to a diagnosis. When we have a patient who is not following along that path, it gets very frustrating for us, and we start to get irritated with the patient because we feel that they're not helping us make a diagnosis. And so sometimes it means that we take a negative view of the patient, and we don't believe them. That we think that there's and we like to give all sorts of titles to this pain, atypical facial pain or something like that. So that so the point is that, did you have that diagnosis? Yeah. So the point is that, but if something is abnormal, then something abnormal is going on. Because we can't know the answer to everything. So you have to be humble and accept the fact that you don't know the answer to everything. And my answer to you is that the patient is almost always right. I've hardly ever seen a patient be wrong in their presentation in terms of telling lies to us. They don't. They tell us what their symptoms are. And so believe them. Always believe them. Even though it's very hard for you because it doesn't match in with what you think. So that's the first thing. The second thing is, Judy said something during the course of that history which is absolutely significant, which if somebody had picked up on it, would have known the diagnosis, know that there was something serious going on. Anybody want to hazard a guess at the one symptom she said that was a cardinal sign of something serious going on? Numbness, exactly. Unexplained numbness, yeah. There's no reason for her to have numbness of the lower lip. No reason at all. You know, taking out a tooth doesn't leave numbness of the lip. So the fact that she had numbness of the lip is a really clear sign of something odd going on. And that could be anywhere along the nerve. It could be intracranial. It could be at the cerebellopontine angle where the trigeminal nerve comes out. It could be multiple sclerosis. But the point is, it is a symptom that you should investigate very, very thoroughly. Okay? So, Nick, do you want to make any comments at that point?
No, I think it's absolutely covered. And one more thing that is noticeable. An experienced maxillofacial surgeon has seen this once in his lifetime, which is true. It's not a negative comment. We don't have more than 200 patients a year with this type of diagnosis. Therefore, because we are fully programmed to access computers, computer search the files that they are in common use. They search the recent documents. They don't search anything that may come across in their lifetime. So it's important to be open-minded and think widely and sometimes outside the box on diagnosis.
Yeah. Okay. Other question? Yep.
Do people tend to present late then because of the sort of problem with misdiagnosis? Or do you see more people being referred at an earlier stage, for example?
No, you're absolutely right. There is no awareness is difficult because it's a rare tumor, so it does fall in the categories of public screening and common symptoms. The most common symptom is unexplained numbness. But if you notice what what Professor Hudson said, this may start from a numbness with involvement of the nerve ending to intracranial involvement. So, and as Judy mentioned, the other thing to be picked up is that her pain radiating to her temple, which also gives the picture of the mandibular nerve direction division. So, as much as we can discuss about this, to me, the main advantage of that talk would be to take the message that unexpected things may happen during your career, so do not expect just to see the 90%. When we say 10%, they're not epithelial tumors, this 10% is very real, exists out there. You're not going to diagnose earlier, but it's important to be able to be diagnosed when the symptoms arise. The worst thing of all, and Judy fortunately was not part of this, is to have people going from dentist to dentist, for example, for a considerable period of time, for several months, to the time that the disease has spread elsewhere, and is not a local or regional disease, it's becoming a systemic problem.
Any questions?
How often do sarcomas metastasize outside their site of origin? How rapidly do they?
More rapid than epithelial tumor. In about 20% of cases already may have lung mets. It's a very common finding to say on the CT scan, as with squares, although the true positive are more common in the sarcomas. Indiscriminate lung nodules. That's a very common description by the radiologist. Now, in most of squamous cell carcinomas, this means nothing. The patient may have bronchitis, the patient may have pneumonia, or TB in the past, is an elderly patient, a smoker probably, so this may mean nothing more than an old infection or inflammatory response to some sort of trigger. In the sarcoma patients, I'm afraid about 1 in 5, these discriminatory nodules were unspecified on the patient's first assessment, may move to frank lung mets. So they were already indeed by the outset lung mets which progressed to noticeable disease. Simply we can't diagnose them from the beginning. Hence, the almost mandatory, almost everywhere nowadays in the world, introduction of neoadjuvant chemo. If you notice what I mentioned, the arguments for neoadjuvant chemo is eventually wipe out any potential microscopic distant, which most in that case are lung mets, and secondarily the effect on the primary disease. The chemo is not as much for the primary disease, it is as much for the potential systemic sequelae.
Many of you may not know what neoadjuvant means.
So
that means that. Well,
no, please answer you.
No.
Okay. Adjuvant, obviously, everybody knows. Neoadjuvant is something to start right from the beginning, not concomitant, not in parallel, to start with, and that's as an introduction to the treatment. And I'm not going to repeat now what's the function of chemo as indicator and for the distant mets, but this is what it is. Obviously, treatment in parallel is concomitant treatment when the treatment is given in parallel with radiotherapy, let's say, and obviously if treatment is post-surgery, is post-surgery or post-radiotherapy chemotherapy.
Okay, I just want to make a couple of comments there. Right from the start of my time as a consultant, I used to send patients to UCH because the UCH had a partnership with the Royal National Orthopaedic Hospital in Stanmore. And the Royal National Orthopaedic Hospital in Stanmore is one of the world leaders at long bone and axial sarcoma treatment. And so a guy there, a delightful professor of medicine there, whose name eludes me just at the moment, started the protocol, the sarcoma protocol, which was in place in the late 80s, early 90s. And what he did was he devised a chemotherapy regime, and the patient would have chemotherapy first, then surgery, then radiotherapy. And so he was doing that with the Royal National Orthopaedic Hospital. Head and neck sarcomas are a much smaller cohort than the long bone sarcomas. And what was happening was that if you were a person in that age group that you saw of the graph right at the beginning, in your teens and 20s, which where a lot of patients were who had long bone sarcomas, you ended up having the whole limb removed, right up to the pelvis, or right up to the shoulder. And even then you weren't curing the patients. But what happened with the chemotherapy was, it first of all meant that, slightly differently to what Nick was saying, it meant that you could do a more conservative resection of the long bone, because what happened was, and I felt this too in doing head and neck sarcomas, was that having the chemotherapy kind of sterilised the periphery. So the point that Nick made about it going right through the bone and roaring away, it does do that. You can't see where it finishes. And that's the other comment I want to make. You can't see surgically where it finishes. And you can't do frozen sections on it. But there are other things you can do, like alkaline phosphatase staining and things like that to the margin, but that's not really that reliable. So you do a good resection with wide margins, and you find tumour at the periphery because it's invisible. It's spread in a way that is not like the great big lump that you could see beyond that. But what I felt was that with the chemotherapy, it shrunk down, it destroyed all those peripheral mets, not peripheral mets, peripheral cells, and you were left with a ball, and you could be pretty sure that if you took wide margins on that ball, that you get all the tumour out. And so that is what I felt about chemotherapy, and that's what they were doing in the long bones. They were managing to preserve long bones and still getting clear margins, so they could put prostheses on. So that was a revolution in the management of sarcoma. It was raising the cure rate, but at the same time resulting in less radical resection. Now, I don't know whether you agree with that, Nick, because you've done many more sarcomas than I've done. But historically, you know, I've had patients with sarcomas who've lived years and years and years and years, like 15 years, and I think it was because of giving them chemotherapy first. I vividly remember a young man who came here and who did not have chemotherapy first. He was under another surgeon, and he had a wide resection, and he didn't get clear margins. I think it was very important to start with the chemotherapy. But you've had patients there who continue to grow despite the chemotherapy, haven't you?
Yes. And this we have mentioned before, but we've just popped out, that we have to have an interim radiological assessment. I mentioned that we use a PET CT after cycle 2 or 3, as you had as well, Judy, to see how the tumour responds. PET CT is not a panacea. You can't say it's the absolute tool to assess, because obviously there is a false positive rate when there is inflammatory or infection, or inflammatory response or some infection close to the tumor mass. That is the best that we have to assess. Obviously, if there is growth during chemotherapy, and there are unfortunately few cases like this, then chemotherapy stops, proceed to surgery. We know, I don't have figures for that, but in these cases, really the non-response to chemo is a sign of biological aggressiveness which may be materialized in a non-successful surgical outcome. Not as much as the primary side, but in this group of people, we've seen quite often removal of the primary disease, clear marks on the primary disease, lung mets which were dormant during the initial assessment because there was a huge lump somewhere in the face. The huge lump is removed in one or the other way, and the metastatic burden just grows everywhere. We've seen this thing as well.
But it's a low percentage, isn't it?
That's a low percentage. It's a low percentage.
Yeah. So I want to come back onto lung mets. My experience has been, again, very limited, but it goes back to the Royal Marsden when I was a junior, and so I've seen it over the years, that if a patient has a lung met, you can often have a lobectomy, a lung lobectomy, and the patient will live an uninterrupted life afterwards for a long time. Does that continue to be the case?
I love your optimism. It's always has been.
That's just my experience.
No,
if it's a single isolated lung met that is within one lobe, that a lobectomy is something that can actually control disease for a significant period of time, many years, without...
You're absolutely right. What we see, though, if I may say, we see more scattered lung mets of not substantial volume, but multiple. But what we have seen, patients having chemo for the lung mets, or even living with the lung mets for a considerable period of time, not an uninterrupted life. Hence, we saw the figures of survival rates from 79, disease specifically dropped to 53, 57. It is not because of the primary disease. One thing that I learned from Ian, and that's very true, is surgeons can control the primary tumor, and the tumor should not fail at the primary site. We cannot control the systemic burden of the disease. That's not a surgical issue. Let's be clear about this. However, it's very important to reduce, to eliminate the primary tumor. If the lung mets do not appear in year 1 or year 2, most probably this patient has been cured. And this is what I have to say. And still, if there are lung mets, my experience at least is that we're talking for small multinodular disease, which may respond to chemotherapy, and people do have a considerable period of time ahead of them. Isolated disease without pleural involvement, yes, respond to it.
Any other questions?
Yeah, do you ever get secondary, like distal metastasis presenting in the mandible first before it's detected going on and then? Did you ever?
I'm not sure that
he has more experience than I have.
I'm not sure that sarcoma, long limb sarcoma, ever metastasizes to the mandible. Certainly, I think I've seen soft tissue sarcomas elsewhere in the body metastasize to the mandible very rarely. So you can find all sorts of oddities that metastasize to the mandible, but it's rare. But I've never seen a long bone sarcoma, and I've never actually heard of it.
Totally agree. I've seen soft tissue sarcomas, I've seen angiosarcomas metastasizing, I've seen rhabdomyoma, but I've never seen bone sarcoma from the limbs coming to the mouth. Never seen it. It doesn't mean it doesn't exist. In medicine, everything exists. But
yeah, just want to say thanks for coming tonight, Julie. It's always great to see patients and stuff like this. I was wondering about when you realised you had to have surgery the second time, what that was like to hear. And I mean, having gone through so much already and finished.
I think if you can say you've you know, if your life is ever going to be in slow motion, that's it. It was devastating, but I knew I could do it. I'd already just done it, and I thought, I kind of knew I'd had a rough time, because my right leg, typical. This was fine. It was down here, the donor side. At the end of it, that's where all my problems were. I knew I could do it, and I would do it again. I knew that, because without sounding really corny, I had such an amazing team around me. I was on first name terms with like all of his crew, and
Well, you can't say my surname, that's the reason.
don't ask me to spell it. And I think that the shock and the trauma of kind of going through this enormous ordeal and then being told, you've got to do it again. You can do it again.
So it was almost easier the second time.
It was easier the second time. And it was easier because I was stronger, but also because I knew the belly of the beast. I knew what to expect. I don't know how many ill patients end up having it done twice. I don't know, because of the nature of the sarcoma. I really don't know. I mean, I know that mentally, and I didn't mention this earlier, it is as hard as it is physically. Chemo was chemo, it made you feel crappy, it laid me low, but surgery, the mental and the physical were as hard as each other, and it was, even when I got the all clear, so I kind of gone through like 5-6 weeks of like this turmoil of, is it going to work, is it going to work? And I just crumpled. I got the all clear, and at that point I'd been really positive up until then, and there was just nothing left. And fortunately, Nick's clinical nurse specialist at the time, Maggie, she picked me up and she said, you need to speak to Changing Faces. And I'd seen their posters around, but I didn't really know who they were, what they did. And they really saved me. I mean, they really are unsung heroes, and I think that, I would love to see one of them on Nick's crew as a permanent fixture, because I want my surgeons to be the best that they can be. But I would really have wanted someone to just help me out with that kind of mental, just to have a counsellor there, really, in the background, in the wings, just keeping an eye. That would have been good.
I think that's two very important topics. Number one, what you just mentioned, the need for support, not only the physical grounds of surgery or chemotherapy, but also on the psychological impact of having a beautiful young woman who goes with no hair, then changing the face forever, re-changing things again, and the meantime crippled because someone's operated both legs. That's a huge physical deformity and mental stress. And I think there are very few people, and Ian is one of the few that have picked up the importance of this. Through Saving Faces, we have one of your students coming and joining UCH, but it's true, there is no regular support, as it should be, for people in going through such a massive treatment.
And I think it, sorry to butt in, I think it would make your jobs easier if there was that support of the crew, because I think that the patients, when they do see their consultants, it's for up on the ward say. So you've done the surgery, and Nick will come round and see me at about 8 o'clock, 8:30 in the morning. And it's just a quick, check. And I think that the patient, because they're just reaching out for they just need somebody there to talk to, and that is when the counsellor or support network would come into their own, where I think it would relieve you guys of quite a lot of tension that you must get from the patients, that's sort of unduly, it might get in the way of them describing to you how they feel. I mean, bearing in mind I couldn't talk at that point.
Exactly the way. I'm just not professional about it. I feel helpless to help you appropriately. This way I think is important. It's important to have someone who professionally can help you out. And that's another aspect, if I may, and just for this. My main worry, I come now to the physical input, which I think we discussed at the time, probably as the time goes, we forget things. My main worry is that a month or 2 months post-surgery on one leg, if you know that we discussed it to go through the second one, and I think also you got a lot of help using physio outside the hospital.
I did.
And one of the things that we learn, we concentrate very much on what we do here, which is great, but if you notice what Judy mentioned, is a full body treatment. And is here, was here, the jaw is everywhere.
Any part of me that wasn't touched, honestly. Peg tubes.
Yes, we had this as well. Yes.
I had, God knows how many, I mean, tubes, dry swallowing.
But what did you say about the mark that you had?
Oh, God. The second operation, and I noticed I've got this strange sort of, it wasn't a burn, it wasn't even a bruise, there was this strange brown mark on my chest just here, and I said to Nick afterwards, what's this? And he, honest to God, he looked at me and he laughed and he said, Julie, I've done many things to you. I've broken your legs, I've done all sorts of things to you, but I didn't do that. And it was like, at the time, because there were so many people working on me, there was a team down here, there was a team up there, there was the anaesthetist, it was just madness. Well, it wasn't madness because they did the job they had to do, but it was just, I found it quite amusing, I think Nick found it quite amusing, because, it's a huge operation. Of course there's going to be bits and pieces that have, I don't know, what
does anybody want to ask a question? I want to make a comment on all that. Anybody want to make a question? Yes, go ahead.
Obviously, because you had most of your jaw removed, how important was the oral rehabilitation? Like all the implants and
well, no, it's a great question. My speech therapists were really concerned for the second operation because I'd had one trachea already and I would have to have a second one. They were concerned that my speech could be damaged, might not, a slim chance it might not come back. That was a major concern, and also the swallow. They were very concerned about that, and I spoke straight away due to the team's efforts. And that actually was a huge worry. I think that was lifted, and it wasn't really a problem because I can't give you the reasons why, but I know that there were concerns there to begin with, but actually as I came around and recovered, it was a lot better. I mean, the swallow tests that I did, what's that video? Yeah, that was fine. I actually started drinking fluids quite quickly after the second operation, which I think was also largely because I was much further away from chemo, because the first operation, do you remember the flap, there was a little hole that it wasn't kind of healing properly, and they were worried that it would leak, but it's because the chemo really, it compromises your recovery, because it slows things down so much. So I was lucky, I think, and I was also in very good hands. That's why it was okay.
Does the chemo affect success of the flap?
Very good point. The answer is I prefer to operate patients after chemotherapy. Certainly I don't enjoy to do this after radiotherapy. The published data is that chemo should not affect as much. Radiotherapy affects vastly. Is not as much as the technicality of trying to do a flap. It's more the healing process that is impaired by chemotherapy. And please not forget that in theory, we should operate within 3 weeks following completion of chemo. I don't think that I ever did, and don't think that I should do that. Because not only the operation to go through is the initial aftermath, the ebb and flow event of the surgical response, the surgical stress. So I will operate between 4 and 5 weeks. Not more than after 6 weeks, because you lose the benefit you have from chemo. But certainly 3 weeks is really very close. So is the systemic, not the technicality on the flap.
There are 3 things I want to bring up. I want to bring up about the neck. I want to bring up about the psychological aspects, and I want to bring up about harm. Above all, do no harm. We don't have to take the Hippocratic Oath, but one of the features of the Hippocratic Oath is above all, do no harm. And of course, when we're operating to take other parts of the body to reconstruct, to transplant into the face, we are causing harm by definition. Surgeons always cause harm. So the question is, how can we keep the harm to a minimum and yet solve the problem we have in the head and neck? But I want to come back to the side. Well, I want to go to the simple thing first now. What would you say is the only positive thing about sarcoma surgery in the head and neck?
But I'm going to have a job for another 10, 15 years.
Yes.
No.
Do you do a neck dissection? Does it metastasize to the neck nose?
Okay. I'm not going to give the answer that you expect, because I will say that everything depends on the pathology. And if we're talking for bone sarcomas, because this is what ear probably means, the answer is no. The easy thing on that is we don't need to do a neck operation for bone sarcomas, for osteosarcomas, chondrosarcomas, chondroblastic sarcomas, or Ewing's. If we're talking for soft tissue sarcomas, and we have joint pacing with soft tissue sarcoma, the behavior of the disease is completely unpredictable, and there are no data about this, because simply there is no part of the world that there are that many of that lot of alveolar sarcomas of the soft tissue or spindle cell sarcomas. By the way, if I may disclose this, Judy did not have, you had a soft tissue sarcoma of the bone. You had a leiomyosarcoma of the mandible.
What does a leiomyosarcoma mean? It means it's a muscle myosarcoma. Lyo is smooth muscle, as opposed to rhabdo, which is striated muscle. Okay? Yep, all right. So did you do a neck dissection, a formal neck dissection?
No.
No, there we are. Okay. So let's dispense with that. So that's the first thing. And that's an important thing to say for the surgeon, but it's also an important thing for you to take away that in a sarcoma, a bone sarcoma, you don't need to do a neck dissection. But of course, you do need to open the neck to gain access to it, to the tumour, and also to do your reconstruction.
Just to also add in, I mean, it open, I think, if I've counted this up right, it was once, twice during the first lot, so you opened me up twice, and then again for the second big op, so that's 3, and then when you got the plate out. So this side has been opened up 4 times.
Yeah. Okay.
And this side, yeah.
But let's move on to the
Let's move on to
the other thing. Let's move on to the other thing. Okay. I'm going to come to the harm last of all. I want to ask you a question. Does Nick kiss you?
I don't know.
He's
No.
never kissed you?
Of course he has.
Good, okay, fine. I want to tell you,
Because
the only thing...
I will tell you something.
I'll tell you what.
Oh, you want to say Nick, or shall I say?
So you say that.
Okay. So we have a farewell dinner, because we know we're getting rid of the Greek. He's getting we're getting rid of him, he's going away. So we're having a farewell dinner. We've even contributed to it just so that we can get rid of him. And he stands up to make a speech and he says, this surgeon taught me this and that surgeon taught me that. And then he says, the only thing that Ian taught me was to kiss my patients. So if I've taught him nothing else, he kisses his patients. Okay?
When I just come round, and I remember I was saying to my husband, I was out of it, you know, I was still kind of, I was in intensive care, I was going, oh. And I said, are you going to kiss me then? And he looked at me and he just looked horrified because it was, you know, he just didn't want to hurt me. And because I hadn't seen myself, and then literally the next day, and I saw him, and it was like smack. And that was
so I want to actually come on to the psychological side of things. So actually, we've had lots of psychologists talk to us, and we actually had Professor Anya Korjan come and talk to us. I can't remember, was it on the Reconstructive talk or I can't remember now. But she came and talked to us about, and she's supervising our PhD students, one of whom is over with Nick, and we've got a trauma PhD student as well, a psychology PhD student. And what she found with my patients was that they were doing a lot better because actually the truth is, I'm going to say something really dramatic now. I'm not really a surgeon. I'm much more interested in the patient than in the surgery. You know, if I could wave a magic wand and get the right answer, then you know that would be what I'd like to do. Because we have to, you know, you talk about the stress you have. Bloody hell, you have nothing. You're asleep while we're doing this operation. You're having an easy time. He's stressed out, and I know that because I've been in theatre with him. He's shouting and throwing instruments around all over the bloody shop. The point is that we have a huge amount of stress. Fortunately, when I get to theatre, I've suffered all my stress beforehand because I've planned the operation beforehand. I've tried to work out every possible eventuality that might go wrong, and so normally I enjoy the operating experience, but it's physically arduous because they're all long operations, and so you know, if we could get a magic wand and do it, that's what I like. So what I love is spending time with the patients in the clinic, and of course because we're only operating on a few patients every week, we get to see those patients for longer periods of time, and so we form relationships with them and their family. So what the psychiatrist told me is that, unfortunately, you're a very bad person to study as a surgeon because you're acting as your own counsellor for the patients. And I actually bet that Nick, in his outpatient clinic, does spend a lot of time with patients and does listen to them, and because he's interested in their lives. Now, then we come on to the other aspect. You've talked about yourself, but what goes on in the rest of the family? Here's a husband at home looking after the 1.5-year-old, worrying whether she's going to live or die, worrying what he's going to manage. How many children do you have? I heard you say you're having IVF, but
yeah,
so
I've got one son.
Yeah.
And
so you know what? I mean, we're running out of time, but the truth is, it's the psychological aspect is not just the patient; it is the whole extended family.
Yeah, that's very true.
Yeah, and so I'm not belittling your experience at all
No,
by
not
any means.
at all.
I think, I don't know, I can't immediately think of a patient who has had to go through, shortly after their recovery, go through the business of having the whole lot taken out and thrown in the bin and starting all over again. I've known that we've had to do things down the line if the reconstruction has failed or something else, but not if you go back. So I think it's incredibly brave of both of you to do that. And what I say to my juniors is, when they say, what do I need to be a surgeon? I say, above all else, you need courage. Because you go in there, you know that things have not worked out perfectly, and yet you're prepared to go in again, into the breach again, and do it again. So I think both of you have been incredibly brave. And so the only point I wanted to make was, and it's a point for you to take away and think about, because we don't have time to explore it, and it will be worthwhile spending an hour or two exploring it. And I think we can arrange that if you want to talk about it with your husband and things like that, but maybe it's past and you don't want to talk about it. But the point is, that it is the whole family. And then, of course, we have the other thing now, the leg. The final question about the leg. Is it better now, that thing, or is it still there?
It's plateaued out. It's nowhere near as bad as it was. I mean, in the early days, like I said, when I was in recovery and say, you know, foot's in plaster and I'm laying cables sort of around my feet, and I could feel, you know, I could sense this. It was just so big. And when I was walking, it was very difficult because I couldn't put my foot on anything cold. I couldn't put my foot on carpet because it was so hypersensitive. And then I think it took about a year for that to kind of dissipate and really. And now it's always tingling. When it's cold, it's worse. When I'm tired, I do tend to get quite fierce cramps behind my knee sometimes, but it's all right. You know, considering what it could have been, it's actually, I can do it. I've got heels on. You know, I walk 25 miles a week at work, generally, so it's not hindered me.
You've been terrific.
Thank you for having me. Thank you for having us.
Yeah. Nick, you've been terrific as well. Okay. Keep kissing the patients. Thank you so much for coming on. It was brilliant.